Good afternoon, everyone. I'd like to welcome you to today's Pediatric Series webinar. Our topic for discussion will be on neonatal jaundice, and our speaker for today is Dr. Fanny Sokara. She's a consultant neonatologist, running her own private practice and working in various hospitals in Nairobi. She has a special interest in transports, in neonatal transports, and neonatal perinatal palliative care. Welcome, Dr. Okara. You can go ahead and share your screen.
Thank you, Mukakenya Kailemia. Let me just get my presentation. It's this one. Just want to be, yeah, okay. Yeah, so thank you for the very generous introduction. I just wanted to kind of talk about neonatal jaundice because I think we've sort of touched on other issues. It's a sort of forgotten illness that almost every baby in NICU will have. Because neonatal jaundice is quite wide, essentially what I'll touch on is the acute aspects of neonatal jaundice and mostly talk about what affects babies in the NICU. And then focus on the practical aspects of treating and dealing with neonatal jaundice. And then we'll try to sort of bring it into the perspective of KNH so that it's more practical for people there. One of the reasons why jaundice is quite important in the neonatal period is it's the sequelae of it. So if unchecked, babies can develop significant neurological issues that will affect them for the rest of their life. It's very difficult to get specific numbers on jaundice because almost all babies in NICU will have jaundice at some point, especially the preemies. And it's an easy thing to treat. It's an easy thing to screen. It's very easy to prevent as well, basically. And I think other than HIE, it's one of the sort of second most successful litigation cases that a pediatrician will sort of face. Successful from the perspective of the parents in terms of if they want to litigate, and unsuccessful from the perspective of the pediatrician. So we'll go through introduction, sort of the nitty-gritties of the science behind jaundice, neonatal jaundice, and then look into the causes and the different aspects of jaundice. Then touch on the presentation, which is quite small and kind of significant. And then the investigations and the management and the complications of certain aspects of it. And then look at the prognosis and follow-up, basically. So, as I said, it's a commonest thing you'll find in clinical presentations. I think I remember from when we were doing postgrad, the numbers used to be, 50% of term babies, which I don't think is that different, basically. So it's almost 1 in 2 term babies will get jaundice, and almost all preterm babies will get jaundice. And then it's essentially the yellowness, discoloration that you see on the skin, on the mucous membrane, which could be the eyes, below the tongue. Basically, that's what you'll see. And it spreads from the head, so from the head going down, basically. There are 2 aspects of it. There's the physiological one, and there's the pathological one. So today we'll talk mostly about the physiological one, because the pathological one, essentially that's more of the gastro aspects of it, unless there are other aspects to it, basically. And by that point, you're referring the patient to another subspecialist. But it's good to kind of just be aware of that. So jaundice is essentially just hyperbilirubinemia, and almost all newborns will have hyperbilirubinemia. So normal levels of bilirubin will be up to about 17 micromoles per liter, and almost all newborns will have higher levels than that, So in the 200s and the 100s, 300s, basically after birth. So essentially, the question is whether they need treatment or not. And it's benign. It can get severe, as I've talked about before. And that's what you kind of need to watch out for, basically, and need to treat that very early on. And then in extreme cases, you can get hyperbilirubinemia, which has essentially crossed over to the brain and caused significant neurological damage. So, so fetal life, in the fetal life, red blood cells will live to about 70 days. And then in the adult life, red blood cells will live up to about 120 days. So that's roughly about half of the, or 60% of the number of days of adult red blood cells. And so they get destroyed a bit faster. And essentially that's what kind of just leads to the whole idea of hyperbilirubinemia, basically, because we know that bilirubin is a sort of like a sub-product or a product of RBC production, basically, destruction rather. It takes a while for the a newborn liver to be able to have functional enzymes to actually be able to conjugate and help in the clearance of bilirubin itself. And that's what ends up with the accumulation of bilirubin, basically. So it can take roughly 2 weeks, 1 week to about 3 weeks, basically. If it takes longer than that, then there should be concerns about the enzyme action. And mostly in those cases, you're starting to refer the patient over to the gastro population doctors. As I said, so 80 to 90% of that will be because of the breakdown of red blood cells, and then the other small percentage will be other heme-containing proteins. So you start off with mostly red blood cells, then in excessive number, which are then destroyed. You get heme, which is then converted to biliverdin and then bilirubin. You get unconjugated bilirubin at this point. That's lipid, it's less water soluble and more lipid soluble, basically. That can cross over to the brain, but most of it will be in the circulation, will sort of attach to the albumin, which will help to carry it forward and bring it to sort of present it to the next level of the process of elimination of bilirubin. So that happens in the liver, and then you get it to be, so it's unconjugated and then turn into conjugated bilirubin, which is water soluble, passes into the GI system, and then it's excreted either through the urine and the stool. Sometimes you can have conjugated bilirubin, then reversed in terms of to unconjugated bilirubin, and that goes back into the circulation. And that's what you call enterohepatic circulation of bilirubin, basically. But in most cases, you have red blood cells that are broken down, which ends up into conjugated bilirubin, which ends up in the GI, which is either, and then some of it can be passed over into the urine system, and it's excreted either through the urine or the stool, basically. So the rate of production has to be slightly, is usually, will be a little higher than the rate of elimination. Now, if the rate of elimination is massively lower, then you'll have a massive hyperbilirubinemia that the baby will not be able to handle. And so that's where you come in terms of management, basically. So the bilirubin production rate will depend on the hemolysis. So if you have a higher rate than normal of hemolysis, and we'll talk about things that can cause it to be higher, then you'll have a higher production, which the liver will not be able to sort of manage in terms of elimination and excretion. And so that can end up with causing toxicity, basically. As I said, the clearance essentially is through the GI and the urine system. Yeah, sorry, I'm in another meeting right now, Doc. Sorry, someone in the background. So essentially it's excreted as conjugated bilirubin, which is more water soluble through the bile and into the urine as well, basically. We've talked about enterohepatic circulation, and the enzyme that essentially helps the bilirubin to get to the conjugation state is UGT, basically. The activity of this enzyme should be normalizing at about 2 to 3 weeks of age, or be able to actually help in excretion of bilirubin. But if it takes longer and longer for that to happen, then that essentially leads to the accumulation of unconjugated bilirubin. And so at this point, this is when you start to talk about pediatric GI consultants, basically. So as we talked about, physiological jaundice will be what the normal baby will go through, basically. So they had a high load of RBC during the fetal life. Right after birth, they start to get increased breakdown of RBCs. The liver is immature to sort of clear this out completely. But in most cases, that clearance matches the breakdown. And so it doesn't cause toxicity and you don't need to do anything about it. So this will start roughly after 2 to 3 days, and then it peaks at day 5. And by the 2nd week of life, that should have resolved. So very unlikely for you to be sending a child home and for the parents to be telling you that the jaundice levels are higher than when they were actually in hospital, especially if they leave after day 5 of life. If this process, if the rate of production is way higher than the rate of excretion, then you end up in a pathological situation. In cases of prematurity, then it also needs sort of a remedy to be done, basically. Now, there are certain situations in a term baby where the rate of breakdown will be much higher. So if you've had any sort of instrumental delivery, or if this was a traumatic delivery as well, then you end up with injuries and bruising, which can actually accelerate the rate of RBC breakdown. And so when you've attended a delivery and you know that the baby has a cephalohematoma or a bruise, a massive bruise on the arm, or on the back or on the face or something like that, it's worth just watching out for jaundice. And essentially, those are the kind of babies you want to screen a little earlier, basically, just to be sure that you don't underestimate the level of jaundice they have, basically. So in pathological cases, this actually requires treatment. You need to actually investigate the baby a bit more. This will be seen in cases of hemolytic disease. So if there's rhesus incompatibility, so where the mom is rhesus negative, the baby is rhesus positive, we rarely see these cases, especially in developed countries, but we do see a few cases, 1 or 2 cases in developing countries now. That needs urgent attention. And this is something that you would have noted in pregnancy. So the obstetrician will probably let you know that this mom is rhesus negative. We gave anti-D during pregnancy, and we're expecting no issues during delivery, but it's something that you just need to kind of watch out for, basically. There's also ABO incompatibility that can happen, and in most cases, this will happen when mom is O positive, or sorry, O, blood group O, and the baby is either B or A, meaning they have, mom has antibodies that can actually sort of affect, sort of increase the breakdown of baby's red blood cells, basically. It's important to know whether there's been a family history of jaundice. So if this is not the first baby, just ask about whether the previous baby had jaundice, whether they had to stay a little longer in the hospital for phototherapy. Has there been a history of exchange transfusion? Has there been any history of any pregnancy losses, or any early neonatal deaths, basically? So these are significant. And then the history of jaundice within the first 24 hours. So this is significant because it kind of alludes to something may happen and it leads you early on. I don't know if obstetricians do this, but I know in other countries, they sort of screen pregnant women for other antibodies other than the usual ones, the ABO and the rhesus ones. There are other antibodies that they sort of screen for. And as a neonatologist or as a pediatrician coming in for a delivery, that's quite important for you to know, because it gives you an idea that other than ABO or rhesus, there could be some other hemolytic process going on. And you sort of need to be aware of this basically. So these are babies that bilirubin levels may need to be screened before the 24-hour mark, basically. So, and then there are other cases where the onset is after 24 hours. And usually in these cases, it's important to find out about the feeding, whether there's been urine that's been passed, how is the level of activity of the baby, was there any sort of infections, anything that will trigger you to think that there could be increased hemolysis, or that the level of fluid status of the baby is much lower than anticipated, basically. One of the other interesting cases is an unwell neonate, and this can present in two ways. So you can have acute bacterial infection, and so say something like GBS or E. coli, something like that early on, and the baby presents with jaundice, either around day 2, day 3, something like that. There are cases where you can have baby born, they look like they have high drops, they look jaundiced, you check their bilirubin levels, they are much more significantly risen, and then and they may have anemia as well. So in those cases, other than just workup for, is this ABO or rhesus incompatibility, you also kind of need to watch out for TORCH. I think last year in Canada, they had to change their guidelines. Is it last year or a couple of years ago, basically, because they'd seen there's more syphilis, congenital syphilis popping up in Canada and North America, which then, if undiagnosed during pregnancy, these are the mothers who deliver and the babies come out completely pale, jaundiced, and in your workup, you find out that they actually had congenital syphilis. These babies sometimes actually just need exchange transfusion very early on in after delivery. The other aspect of pathological jaundice will be prolonged jaundice. So if you see jaundice beyond 14 days or 21 days for a preterm baby, that needs to be investigated thoroughly. And then I think something else I haven't put in here is conjugated hyperbilirubinemia. So in most cases, physiological jaundice will be unconjugated. So if you see higher levels of conjugated hyperbilirubinemia, that needs to be investigated. And there could be sort of innocent reasons why that's happening and other reasons where it's not so innocent, basically. So by innocent, I mean if you have a preemie in the NICU, they've not been feeding for 2, 3, 4, 5 weeks, basically, they may have more of conjugated hyperbilirubinemia. That could be because they're on TPN or the fact that their GI system is essentially just inactive completely. So those are certain issues, basically. You start feeding them and the bilirubin just starts to drop significantly on its own, or not on its own, but with other remedies, basically. And in other cases, you could be dealing with obstructive, what do you call it? GI obstruction or biliary obstruction as well, which could actually just give you high levels of conjugated bilirubin. So in such a particular case, you need to investigate quite early on and essentially get the surgeons involved much, much earlier on, basically. Okay, so the presentation will be jaundice, and then this will be yellowness of either the skin, yellowness of the sclera, yellowness of the mucous membranes. And as I said, it's craniocaudal, basically. So you start off, it starts off usually in the head. So if a mom calls you and tells you there's jaundice around the head, but the rest of the body kind of looks pink, I mean, it's good to screen, but you're sort of not so worried about that. So probably the jaundice level could be between 100 and 200 or so or less. there could also be the issue of anemia as well. And this comes into the perspective of what's actually causing the excessive hemolysis, if there's excessive hemolysis, basically. So that could be the other presentation. So something I needed to mention with jaundice is we need to be kind of careful in the population we're in. I think the darker the skin, the more difficult it is sometimes to figure out where there's jaundice or not. And this is where sort of cases of litigation comes in, especially in the West, where like a Caucasian individual or doctor has sort of underestimated the level of jaundice in a child of a different race, basically. And so by the time it's actually picked up, the child has features of kernicterus, basically. So certain screening tools have to be put in place so that these things are actually not missed. Depending on the level of jaundice, I think if you have severe jaundice, then it starts to affect the mental ability of this baby. So the mental status, so they become more lethargic, their feeding sort of decreases, and the feeding can be either a consequence or a presentation of what's happening, basically. So it can be that the baby is poorly feeding, mom has no milk at all, the baby hasn't taken anything much, and so they are dehydrated, and then they end up with jaundice, basically. Or it could be that the baby has had significant hyperbilirubinemia, unconjugated, it's crossed over to the brain, started to affect the baby's activity, and the sac and the other reflexes have come down, and the baby is actually poorly feeding. And then there's the neurological aspects of it, basically. So the tone of the baby will be affected, the activity will be affected, and there will be an abnormal cry as well. So either there'll be a reduced cry in terms of the baby's going into a coma, and activity as well, or there'll be this very high-pitched cry as well, basically. And in some cases, you could have seizures, which are very clear clinically to see, but sometimes if it's not very clear and easy to see, then you might need AEEG. So that's amplitude EEG, basically, that's used in newborns to sort of screen for electrical seizures. Other ways seizures could present is apneic episodes, and the apnea could also be just a manifestation of neurological dysfunction. So this is sort of the new term in terms of, or the term that's usually used to sort of indicate neurological dysfunction. And it's essentially bilirubin-induced neurological dysfunction, and it can be scored. So there's the mental status aspect, there's the muscle tone, there's the altered cry, and you just assess them every day. So if you have a baby who has hyperbilirubinemia beyond a certain level, so, and we'll look at the different sort of screening tools and thresholds. At that point, if they've crossed a certain threshold, then you have to start screening them and scoring them every day to sort of see where they are on the BIND score, okay? Now, of course, if it's 0, then that's a normal infant. If you have between 1 to 3, then this is mild encephalopathy. 4 and 6 is moderate, and 7 to 9 is severe encephalopathy. It's much, much higher in babies who have a bilirubin above 500, but I think anything above exchange transfusion level would prompt anyone to start scoring this baby and start treatment as soon as possible. So with kernicterus, essentially this is the neurological aspect of jaundice. This is what we worry about, basically. So you have unconjugated bilirubin that's crossed over to the brain and started causing damage to the brain. There are specific areas that are usually affected, and that would be the cerebellum, the basal ganglia, and the oculo-auditory aspects, basically. Now, if you notice that basal ganglia is also the aspect of the brain that's affected during an acute HIE episode. And other than the discoloration, you may not be able to sort of, and the presentation, basically. So kernicterus is something that would present a little later, and then HIE is something that would present very early on after delivery, basically. Okay, so if you have a baby who's had bilirubin levels above exchange level, they need to have an MRI done, because you need to be able to see whether they've had any injury to the brain. And so that's a baby who will need follow-up with the pediatric neurology, just so that they can continue to be followed up and actually sort of anticipate what sort of delays they may have going forward. So if you suspect that a baby has jaundice, one of the main important things is to just confirm that with the bilirubin check. You can either do this using a serum check, also you check the blood level basically, or you can do a transcutaneous bilirubin check, and we'll talk about those two. The other thing to do is to just rule out any pathological issues. So the baby's blood group is important to know. Mother's blood group will come from the antenatal records. If that's not available, then you have to get mother's blood group as well. And then there's the presence of antibodies, basically. So there's the rhesus antibodies that are checked for. And then I said there are other additional antibodies that in some places that's also checked for during pregnancy and then monitored. Part of the other thing to find out during pregnancy is whether there was any interventions done by the maternal fetal team, basically. So in some cases, if the hemolysis is so significant and the baby has anemia, then the baby may end up getting in utero transfusion, basically, which we can talk about on another day, basically. Then direct Coombs test tells you whether there's, kind of gives you an idea of what's going on, basically in terms of hemolysis, and guides you going forward in terms of what to do as well. If you do a CBC, I think it gives you a good indication in terms of infections, but also in terms of the hemolysis. So if you have a high bilirubin level and a low HB, then it gives you an idea of what's happening in terms of the hemolysis. The other thing to look at is platelet counts, because if you look at most of those TORCH screens, the TORCH diseases, basically, some of them cause thrombocytopenia. Then the neutrophil counts and the lymphocytic counts also kind of give you an idea of what's going on as well. I think if it's early on and if it's physiological, sort of the test on the, which side is this? The left side, sort of your basic screens. But if you're dealing with bilirubin levels that are a bit more significant, or you're concerned about the pathological aspects of it, then doing a full liver function test is important. UECs are important, especially if you're bringing in a child from the postnatal ward into the NICU, because you kind of need to figure out whether this is more of a dehydration aspect or is there something else going on. Then there's the septic screen as well. So the blood cultures, this would be early on in neonatal sepsis, early onset sepsis. And then if you're dealing with something, and TORCH screen early on as well. And then if you're dealing with something significant, then you look at the urine cultures as well, basically. Can screen for G6PD. This would also be something that would happen a little earlier on as well. And then thyroid function tests, which would be something more towards the something later on, or prolonged jaundice, basically. Now, imaging depends on what you're thinking of. If you have bilirubin levels above exchange transfusion line, then a head MRI would be important, especially if you're seeing some neurological symptoms. And then if you are concerned about biliary atresia or any obstructive biliary issues, then it's good to do an abdominal ultrasound, basically. And you could be able to actually see a cyst as well, which would be able to help you make a diagnosis and sort of refer the patient early on to the surgeons. Now, so in terms of bilirubin checks, so an easy check to do is a transcutaneous bilirubin check. So you have a little machine that you kind of just put on the baby's skin, and it gives you a value, and that helps you to sort of figure out, do you need to do the next step, which is essentially do the serum check, or is this maybe okay enough to kind of go home, or just continue with normal routine neonatal care, basically, or postnatal care. It's more accurate in closer to term babies and babies more than 24 hours of life. I think when the studies were being done in the trials, if that was the population that was used, I've seen it in some centers being used in babies who are less than 35 weeks. But I'm not sure how accurate that is, basically, because most of the trials were done in children more than 35 weeks gestation. The reason I think they go for more than 24 hours of life is because if it's earlier than that, then you should be thinking about pathological jaundice. And so it's you kind of need the serum levels to be able to figure that out, basically. Of course, it gives you a total bilirubin level. It doesn't quantify to you the conjugated and the unconjugated. But it's a nice screening tool that you can essentially have midwives doing on postnatal babies in the wards, basically. Once you start treatment with phototherapy, you can no longer use the transcutaneous bilicheck. You have to start. You have to continue using the serum bilirubin, basically. And then you definitely don't use it in babies less than 24 hours. And we talked about gestational age. And if you have a transcutaneous level that's close to the phototherapy line, or roughly above 250, then the best thing to do is to just get a serum level to actually confirm. Now, this machine needs quality checks on a regular basis. Otherwise, you'll get serum levels and transcutaneous levels that are completely off the charts. And so it becomes unreliable and difficult to actually use it as a way to assess the baby. Yes, so in terms of management, so there are different things you can do in terms of management. The specific treatments with phototherapy, exchange transfusions, IVIG, and then there's the supportive aspects of management, basically. Now, I think in terms of supportive management and specific managements, one of the things you could easily do is fluid management. So if you find the baby is dehydrated, especially within the first, say, 24 to 48 hour mark, and the mom gives you a very strong history indicating that the baby has not been feeding well or she doesn't have enough milk, then fluid management will actually help you to sort of flush out that extra bilirubin together with phototherapy, basically. If you're suspecting sepsis, then you have to treat for sepsis as well, whether that's the TOT screen or the acute bacterial aspect of it, basically. And then in terms of fluid management, one of the other things I wanted to say is if you can get mom to give you milk, then that actually helps out in terms of getting the process started and actually eliminating more and more bilirubin levels. But if you can't, then you are admitting the child to NICU anyway, then the best thing would be to just do IV fluids if you can. So if later on you start to notice that the unconjugated bilirubin levels are quite high, the conjugated bilirubin levels are low, you're within the, say, the week 2, week 3 mark, which by that time you should have started to see some better activity from the enzymes. One of the things you can actually use is phenobarbital. But I think at that point, you should start talking to the GI team, basically. There's part of what you do in terms of if you're suspecting neurological concerns. So in some centers, once the baby crosses that exchange transfusion level, then that baby requires audiology screening. And in some cases, they actually repeat the screening again. So you can have a baby who had hearing screen done at birth or at the time when they were going home, and the mom brings the baby back, say on day 7 with exchange level bilirubin levels, basically. And so at the time you're discharging them home again, you would repeat the screening, because we know that the bilirubin actually, unconjugated bilirubin has a massive effect on or damage onto the audiology, those areas in the brain, basically. So there are other aspects in terms of management that need to be sort of followed up with, and we'll talk about those as we go on, basically. So there are different types of phototherapy machines that you can use. These are the kind of modern ones that I put up, basically. And so at the top, this is just the Billy blanket. It's quite expensive, so some centers actually don't have them. But one of the useful things about it is, as you can see, this mother is able to actually breastfeed her baby. There's the eye, what do you call them? The eye covers put on, but essentially this is a baby who doesn't need the eye covers, basically. You can take them off. You can have the baby on the blanket, and they can easily stay with mom in the same room, and she can keep feeding the baby as often as she wants, basically. So that's the advantage of that. In some cases, it gives you an extra layer of phototherapy. So, so there are different charts in terms of treatment for phototherapy. So there's the North American charts, and we'll go through them. There's what they use in the UK. There also are different charts in Australia, and then there are specific. So I think some of the bigger centers have their own charts based on the deficits, with some of the other charts basically available on the general population. And then you can either give single phototherapy, double phototherapy, triple, quadruple, depending on what you think, or sorry, not what you think, but the level of bilirubin you have. So if you have exchange transfusion level for bilirubin, then you have to start with quadruple phototherapy, basically. So as much light as possible. So this is where you'd have the blankets down, the light above, so that would be double. And with this particular machine here, it has it has intensity up to 5, so 5 intensity. So when it's at max 5, it gives you double phototherapy. When it's about 2 to about 3, then that's single phototherapy, basically. So essentially putting one light above, maybe one on the side and another one on the other side, kind of increases the intensity of phototherapy you're providing. And the beauty about these new machines is that it has very little heat emanating from it. So the issues of dehydration during phototherapy doesn't quite occur as much. So certain charts have provisions for that, basically, in terms of they guide the user as to whether to use single light or double light or triple lights or quadruple lights, basically. Okay, and then you can bring them down as you see fit in terms of the reduction in bilirubin levels. And then, yeah, so there's a level to initiate phototherapy, and then there's a level to sort of stop phototherapy in terms of the charts. So this is the Australian charts. Essentially what you have is a chart for phototherapy and another one for exchange transfusion. And then the different light colors represent different gestational ages. So one advantage for this is essentially you're able to estimate, or rather treat as per the gestational age, because we know that the threshold for each gestational age is different. So the threshold for neurotoxicity is different for a 37-weeker as it would be for a 22-weeker. So you can't use the same threshold to treat both of them, basically. And then in this particular case, yeah, there's also the addition of risk factors as well. So this is slightly similar, or a slight adjustment to what the NICE guidelines have and what the American guidelines have as well. So when you look at the British guidelines, and to be honest, this is what I actually just use. So, and sorry, for all these charts, if you actually go online on Google and you put in bilirubin charts, you'll be able to get different charts, basically. So if you want the NICE bilirubin charts, you just type in NICE bilirubin charts, which are from UK. If you want the ones from the US, just type in the AAP one, And then if you want the Australian ones, you just type in the Australian ones. And of course, once you start with one, that's what you're just going to use continuously to start and stop phototherapy, basically. You don't use one and then switch to the other one and the other one. One of the reasons I like this chart is, so it comes as an Excel. So you can go on Google, click this in, or rather put this in, click it, it will download. And then at this level here, you can change the gestational age. So it comes, I think, all the way from 23 weeks to about 38 and more. And so the threshold will change based on the gestational age of the baby. Now, the other thing about it is it's very accurate in terms of timing. So this is 0. So essentially, when you print this out, the 0 bit will be the time and the date the baby was born. And this is days, basically. So if you had a baby who was born at 6 a.m. in the morning, so you would indicate there 21st June, 6 a.m. And this would be 22nd June, 6 a.m., 23rd June, 6 a.m., like that, basically. Each of these small boxes is 6 hours. So if you sample the baby at midday, then you'd actually plot the results on this line. If you sample the baby at 6 p.m., then you'd plot it on this line, basically, and through, basically. So if it's at 3 p.m., then you know it's halfway through the 2 marks, basically. So that's one of the other factors. And then with the American one, you have to sort of think about the risk factors, who's at a higher risk, who's at a lower risk, and things like that. But I think for this one, makes it, they've put all those things in mind, and it just makes it a little easier for you to just plot for gestation, basically. And then on this side, essentially each box is 10 micromoles per liter. Yeah, basically. And so the blue line is essentially the threshold to start phototherapy. The red line is the threshold to stop, to start, to think about exchange transfusion. And so if you had a baby who at 1 day of life had a bilirubin level of 250, so you'd probably plot it around there and then start phototherapy. And then as you continue phototherapy, if you repeat it the next day and your phototherapy and your bilirubin level is roughly, say, 180, 190, you'd actually check where the threshold is, which should be 250. And because it's less than 200, so which is less than 50 micromoles below your treatment threshold, then you can actually stop phototherapy. And then it's always important to do a rebound test, basically. So once you stop phototherapy, the bilirubin levels will go up again. So the question is, how high is the threshold? How high is the rebound? So if you're dealing with a preterm baby, you have this zigzag sort of plot. So 1 minute they're on phototherapy, then you stop phototherapy. Then the next level is above phototherapy, you start phototherapy, then the next level is below phototherapy, like that, basically. So you kind of need to be able to check and be sure that they are not crossing the threshold. If you're mostly dealing with term babies, so for example, if you had a level of 250 on 1 day, the next day it's about 190. Once you start, so that's the level you stop the phototherapy. And the next day it would be good to check, or 6 to 12 hours later, you can actually check the rebound level. If it's still below phototherapy level, then it means that it's not, the rate of rise is not above the elimination level, basically. So your production and your elimination are sort of matching each other in a way. Okay. The other advantage of this chart is you're able to put in other details like the baby's blood group, the mother's blood group, and the DCT, and kind of helps you to figure out what to do next, basically, or to think about those factors, basically. Now, the AAP guidelines, which I think is what most people use here, you have to think about the risk factors. and sort of plot the baby on the right line, basically. So you have to think about whether this baby is at a lower risk or at a higher risk. Are they at a medium risk or are they at a higher risk, basically? Okay. And then AAP, so these charts essentially deal with more than 35 weeks. So if you're dealing with babies who are less than 35 weeks, it becomes a little trickier. Okay. And then even when you have charts for less than 35 weeks, they're all lumped together, basically. So it becomes difficult to sort of assess a 32-weeker and a 25-weeker all in the same chart because their levels of thresholds will be very different. And then at the bottom of the charts, it kind of tells you what the risk factors are. So is there sepsis? Is there difficulty in breathing? Was there asphyxia? Is there any hemolytic disease? Any factors like that, basically. Okay. Yeah. Okay. And then IVIG. So this is used in hemolytic disease. The aim is to just sort of attach to all the antibodies within the baby's system to kind of reduce the level of hemolysis. So if you have a baby who has bilirubin levels above exchange transfusion, it's something to consider. Now, it doesn't come without any side effects, so it's something to really seriously think about. And it's given in terms of a way to sort of prevent exchange transfusions, because of course, exchange transfusions have their own risk factors, and it can be very complicated and cause significant issues in the baby. So that's one of the reasons it's done. What I have seen some people do is if you have a baby within the first 24 hours who has, DCT positive results, either rhesus negative, positive, or incompatibility, or ABO incompatibility, and the levels are above exchange transfusion. So these are the specific babies you'd think about giving IVIG, and then start quadruple or phototherapy as you try to avoid giving an exchange transfusion. So that would be the sort of the sequence of what you would do in terms of your management. In some cases, I've seen some people in that particular situation where this is hemolysis, so they do an exchange transfusion, so phototherapy, then the exchange transfusion, and then they give the IVIG afterwards. So their thinking is that the IVIG given after exchange transfusion will mop out all the other, the leftover antibodies, basically. The dose is 1 gram per kg, given as an infusion over 2 hours, and then you repeat your bilirubin. If it's still high, then you can repeat the dose, basically. Yeah, that's it, basically. So exchange transfusion is the thing you're trying to avoid, basically, but if it's necessary in some cases, if you are dealing with very high hyperbilirubinemia, in cases where the baby already has started to show signs of kernicterus, then this is a thing that will actually sort of help in terms of clearing the bilirubin as much as possible, basically. So it's a very risky procedure. It's very time consuming, needs expertise, basically, because you use umbilical vessels. If you don't have umbilical vessels, then you need at least one central line, and maybe a peripheral arterial line as well. So in such a situation, I mean, you need people who can actually put those lines in, make sure they're in the right place, and actually understand how to actually do the pull and push procedure, basically. So the aim is to mop out as much of the antibodies as possible. And so you try to give a double volume exchange transfusion. So so one blood volume essentially will remove about 65%. Double will remove about 88% of the bilirubin levels, basically. More than that doesn't actually, if you do triple or anything like that, you don't actually eliminate more bilirubin higher than 88%, basically. So the more mature the baby, the smaller the blood volume per kilo. And so those are things to actually consider. But if you look at the different ranges, 85 mils would actually suffice for both a preterm and a term baby, basically. What you want to do is use fresh blood as much as possible, irradiated if possible, of course, checked for CMV if possible as well. And that's one of the reasons you use irradiated RBCs. And then you can either use a single line, as we talked about, or dual lines. So you can have an arterial and a venous line, and we'll talk about the procedure of actually using both of them, or you can have one UVC, a single UVC, or if the baby is older than that, then you may have to use a central line, basically. This is a procedure that has to be done in the NICU, and the reason for that, or intensive care, basically. The reason for that is you need to continuously monitor the vitals, and then there are other things that actually need to be checked in between. It's a sterile procedure. You need more hands on board. So minimum you can be is 2 people, basically. Actually 3, 2 to 3 people, basically. So you have the one person who's actually doing the procedure. You need someone else to actually record everything down. And as much as technology has moved on forward, I don't think there's any other way of monitoring and documenting everything other than literally having someone sit down with a piece of paper and write everything down, the ins and outs, the vitals, and all the other checks, basically. So different babies will need different aliquot levels, basically. So if you have a baby who's 1,000 grams, 500 grams, you can't use the same aliquots as a baby who's 5 kilos, okay? So different weights will require different aliquot levels, basically. And the reason for that is you don't want to actually cause significant hypotension during your procedure. So it just increases your levels of complications. So essentially what you end up doing is, so you have a venous line in this case. So in this particular situation, the umbilical cord is still available. So the UVC is inserted. And then you have an arterial line also inserted on the other end, basically. So you have a UVC and a UAC inserted, basically. So the UVC will be your infusion in, and the UAC will be used to extract the bilirubin. What you can do, so in this particular situation, because there's no pump, so you use the pediatric infusion set. And so essentially you have to measure how much you're putting in and actually measure what you're taking out, okay? So you use a syringe. You either use, it depends on your aliquots. So it can be a 5 cc syringe, it can be 5 cc, 10 cc, 20 cc, basically, depending on what you're doing. Now, if you have a pump, you can put the blood through the pump, basically. And so you can measure depending on what you want to do. And this is a procedure that you want to do over 3 to 4 hours. So you can actually infuse the blood normally as you would, and then at a rate that makes sense. And then on the other, so you don't have to do anything about the pushing in of blood, basically. All you have to do is pay attention of the pulling out, basically. So the blood out, basically. That's if you have a pump. And it has to be a blood transfusion pump. I don't know what the nurses call them, but just one that's used for blood transfusion. And then on the other hand, essentially, you just take care of the extraction of bilirubin. It's very complicated, so it's not okay. It's kind of complicated, basically, because you have to understand what you're pushing in, what you're pushing out. Make sure that the blood you're taking out is not the same blood you're pushing in, basically. So you have to be really, really attentive. And it's sort of, you can have a complete circuit connected so that at the end of the day, you can actually connect the blood out to a bag on this other end, which helps you to have a closed circuit. On the other end, you can also just sort of have this infusion, like this line sort of draining into a bag, a disposable bag. so that at the end of the day, you'll just pour out the blood, basically. But the whole thing has to be sterile, as we talked about. So these are some of the things that you might need. And then you have the single line. So in this particular case, so for example, if you're unable to put in an arterial line, or it's difficult to access an arterial line, then you would have to use the same line to put in the blood and take out the blood as well. So this particular situation, you have to be very, very careful that what you're drawing out is not what you're pushing in as well. Because at the end of the day, you can start with a bilirubin level of 650 and end up with a bilirubin level of 650 as well. So essentially nothing has happened, basically. And so, yeah, so you just have to be a little more careful. You use three-way taps in both situations, but the aim of the three-way taps is to essentially just kind of guide you in terms of what you're pulling in, what you're pulling out, and what you're pushing out as well, basically. Okay. So exchange transfusions can be very, very, very complicated, and they can have significant complications. So I think in about I've had 3 cases complicate on me. I've had one baby go into shock during an exchange transfusion, and we had to stop the process and actually just give the rest as a transfusion. The baby was already in canicterus. Then had already had significant neurological issues. Then I had one baby who had cardiac arrest during the procedure. So we had to stop and actually give chest compressions and bag. And then we made a decision to continue in that particular situation. And then I've had a child who complicated right after the procedure was completed. And actually that child didn't make it at the end. But there were other factors into it. So the baby had DIC, was an extreme IAGR. There's so many other factors basically in that particular situation. So for that reason, there needs to be experienced individuals doing the procedure. You need to understand exactly what your role is during that procedure. You need to have had at least some experience in terms of seeing one and doing some before you actually, seeing one, taking part in one, and then doing one on your own. That would be the best way to do it. So essentially, observe 2 people doing it, and then take part or assist someone in doing the procedure. And then at least the next time you can at least do it yourself, basically. So, so electrolytes can go haywire during the procedure. So it's one of the things that needs to be checked, especially calcium and potassium as well. And then your hemoglobin levels also are quite important. So before and after, and it also gives you a gauge as to what you did during the procedure. So you don't expect massively reduced hemoglobin level, basically. So if you started off with a hemoglobin of 10, it should not be 6 at the end of it, basically. So it kind of tells you that something went wrong during your procedure. And in most cases, you do checks before the procedure, mid-procedure, and then afterwards, basically. It gives you a good sense of what's going on. Now, if your lines are not in the right place, a lot of things can go wrong. So you can have air going through the lines, and then that can cause air embolus. And if your line is not in the right place, you can end up with neck, because you essentially are interfering with circulation over to the splanchnic system, basically. And so during the procedure, the baby actually has to be NPO. You can give them fluids, which would essentially be dextrose with some electrolytes, depending on what day of life it is, basically. And then afterwards, sort of wait another 6 to 12 hours before you initiate feeds, basically. So, so in terms of the main issues, basically, so if you have a baby who is suspected to have neurological deficits or effects of bilirubin, so this is a baby who needs follow-up regularly. So a neonatologist or a pediatrician can follow them up. If they have significant neuro issues, then or neuro issues, basically, a pediatric neurologist should follow them up. depending on what caused the issue in the first place. If it's a GI issue, then they need to be seen by a GI specialist. If it's a hemolytic issue, if it's G6PD or some membranopathy, then they might need PEDS hematology to follow them up. If they have any deficits, they'll need physio, they'll need occupational therapy, they'll need speech therapy, they might need hearing aids, they'll need an eye checkup, and then child psychologist later on in terms of child education. I think that's it. Can sort of have a few questions at this point, if any.
Thank you, Dr. Kara, for that very informative and very interesting presentation on the recognition and management of neonatal jaundice. I think I'll just go to the Q&A, and if you have other questions, please feel free to note them down now. The first question is from Boaz. He's asking whether self-medication can cause neonatal jaundice.
I'm not sure what self-medication. I saw that question before the talk even started. I'm not sure what self-medication is. Sorry?
I'm guessing maybe, is there any medication
Yeah.
that if you give to the child can cause neonatal jaundice?
I wouldn't say cause. I think it will just worsen the situation. So if you have drugs that can affect your enzyme, your hepatic enzymes, basically, either inducing or not inducing, but the other one, sort of reducing the activity of the enzyme, basically, then that would worsen your jaundice levels. And one of the main ones is, I think ceftriaxone is one of the ones that's mentioned. So your third generation cephalosporins can actually worsen your bilirubin levels, basically. So essentially, you have to be kind of careful in terms of the drugs you're using during the first few weeks, basically, because it might affect the activity of the enzyme.
Thank you for that. The other question, still on drugs, how does septrin exposure predispose an infant who is less than 6 weeks to jaundice?
Septrin. That one I have to kind of look through it, but I would figure it's the same sort of situation, basically, in terms of affecting the liver enzymes. But I can't remember whether septrin also causes increased hemolysis. I can't remember, honestly. I'm not sure, but I have to check that, basically.
Okay, thank you for that. The other question is from Etabale. Does skin color or race affect performance of the transcutaneous bilirubin analyzer?
I don't think it does, basically. I'm not sure whether there's been any studies that's been done on that. I know it's used on all babies. That would be an interesting study question, basically. So kind of trying to, actually, that would be a good study, like in KNH, basically. But I know in developed countries, they've used it for all babies, basically. So they've used it for Asian babies, they've used it for African babies, they've used it for Caucasian babies as well. But it would be a good study to actually sort of just check that, like in KNH. So you do your transcutaneous and do a serum level and actually see whether there's a difference, basically, a massive difference, because that would be the main issue.
Thank you for that. Next question is from Bahati. How early should exchange transfusion be done? Must it always be after at least 2 doses of IVIG?
No. So in some cases, so it depends on what's happening. So it's actually it's very difficult to get IVIG. So even in the best of centers, you can order the IVIG before the baby is born and get it 6 hours, 7 hours after, or even 12 hours after. So if you have baby who at birth, so you suspected that you would be dealing with jaundice or hyperbilirubinemia very early on in the first 6 hours of life, or you did a cord bilirubin level and it was quite high, so you need to do one on the baby, and it's really high above exchange levels, basically. So in that particular situation, you either would start with phototherapy and see how that goes as you start to plan for exchange transfusion. Because remember, exchange transfusion needs, you need to screen for blood, or you need to get at least O negative blood that would cause less of a reaction to the baby. And that you know very well, that's very difficult to get anywhere. Getting blood is very difficult, same as IVIG. But whichever would come fast, and my guess would be that exchange transfusion would be faster to get than IVIG, basically. So in that situation, you'd opt to do the exchange transfusion fast. So, so in some cases, it's been done as early as within the first 6 to 12 hours. And in other cases, that's the exchange transfusion, basically. That's when it's really, really well anticipated. And in other cases, you've been able to avert it, and you can do it a bit after, basically. So it just depends on what you're able to get fast, and then your response to IVIG if you do get it early on. So you can do one dose and you're not seeing much of a change and you're trying to buy time, and it's not making a difference. So I would still go ahead and do the exchange transfusion and probably give the second one after, basically. I hope that answers your question.
I think it's clear. Thank you for that. The next question is from an anonymous attendee who's asking, if you have 2 babies who are born with jaundice, is there a possibility for the third born to be born with jaundice if the mom has blood group O positive?
Wait, let me see. I have to work it out. If you had 2 babies who were born with jaundice, is there a possibility for the third one? I think so if I remember correctly, like with resus, it mostly affects the second pregnancy more rather than the first pregnancy. But with ABO, I think each is different, basically. And it depends on what the blood groups are, basically. So it can. So like I recently had a mom who was O positive and her first 2 babies were O positive, so no concerns there. But the third baby was B positive. So that baby had jaundice, basically. So it can affect, like each pregnancy is separate and each pregnancy is a new encounter. So it's very different as opposed to with resus, where you need sensitization first, basically.
Thank you for that. Our next question, another anonymous attendee. She says, good presentation, Dr. What's your comment on increasing bilirubin levels, yet the patient physically has a tinge of jaundice? So,
okay, I'm not sure about delta bilirubin, but in terms of skin, I mean, that tinge of jaundice, it's very tricky to sort of rely on just your visual acumen in terms of, okay, this looks like a tinge of jaundice. I don't think I kind of need to do anything about it. Yeah, so it's best to actually just measure the levels themselves, and it depends on, the other issue is basically how you're treating the jaundice. So I'll tell you, I think in most areas, what happens is, especially because jaundice is something you can treat in the postnatal ward. So if you have a mom who you've left with the baby, they're rooming in together, you're giving phototherapy, and you've left, so you've told the mom every 3 hours feed the baby, but the rest of the time have the baby in the cot for phototherapy. What mostly happens is once they put the baby down, the baby starts to cry. And so they'll take the babies out in terms of to try and soothe them. So you have to be very careful that it's not an issue of the bilirubin going up, or is it an issue of the phototherapy not being adhered to, basically. So that's one of the other things. So you have to be very careful in the history that the mother or the parent is giving you. You can also find that they are taking a whole hour, an hour and a half to feed their baby, to change the baby. So once they put the baby down, then the baby cries again. So they've taken the baby out. So in your 24 hours, they've probably given phototherapy for maybe 12 hours. And the other 12 hours, they literally were feeding the baby and changing the baby. So that's one of the other things to sort of look at. So in that situation, it can seem like something else is going on because, you know, you're giving phototherapy, but yet the bilirubin levels are going up, okay? And if you're not feeding and the baby is, you know, suffering from dehydration, then your bilirubin levels will continue to go up. So there are other factors to sort of look at, basically.
Thank you for that. The other questions are about phenobarbital. So one wanted a clarification in the role of phenobarbital in regards to the enzyme. The other is about the use of phenobarbital in cases refractory to double phototherapy and in a setup where resources are strained for exchange transfusion.
So phenobarbital, so first of all, you have to be sure about whether you're dealing with conjugated and unconjugated. In these particular situations, you also have to do a full LFT, basically, just to see what the rest of the enzymes are looking at, like, or the other functions of sort of aspects of the liver, basically. Now, phenobarbital is an inducer of your enzymes, basically. So as we said before, your liver is immature, but that will it should start to mature and improve in activity by the 2nd week of life. But you can find a baby who's, say, 2.5 weeks old. And if you look at the conjugated level, it's quite low, and the unconjugated is very, very high, basically. And the baby's feeding well. And one of the things you could do is sort of induce that enzyme, basically, to sort of start conjugating the bilirubin so you can have increased levels of excretion. So that's your role in terms of your phenobarbital, but I don't think it's given very, very early on. I think it's given towards the 2nd or 3rd week. And in such cases, I usually tend to talk to Dr. Ngwatu or someone else first before I actually do it. So just to think about, like, just so you're not missing something else before you sort of label it as, you know, inactivity of the enzyme, and then you start doing something and it's not changing as much as you would want, basically.
Thank you for that response. Our next question is from Michael. During phototherapy, how do you decide whether to use blue or normal white light?
I think essentially what you're going for is the UV light, basically. I think they're mostly blue. I'm trying to think if there's, oh yeah, there used to be, you could use white ones before, but essentially they're mostly blue. So it's essentially just a specific type of UV light, basically. So that's what you use, it's a specific UV light.
Thank you. So is there a benefit of sunlight exposure?
To be honest, very, very, very little. It's actually, like, if you look at a lot of guidelines, if you look at Australian guidelines, if you look at Canadian guidelines, it's actually discouraged. But it depends on where you are and what you have, basically. So it's good to have a measurement of your bilirubin, and then so figure out where you are. So I don't think you would look at the baby and go, this looks like a tinge, let's send them home, without actually checking the level itself. And you have to be able to sort of ask them to come back, basically. So I think that's the tricky situation, basically. But I think a lot of, there's very little benefits, basically. And it's actually being discouraged more and more.
I think the next two are comments. Yes. So the effect
one.
Yes. So I think one mechanism. Okay. Septrin displaces bilirubin from its binding sites in the liver, therefore releasing the bilirubin to the blood, which now predisposes it to the brain. Septrin, this is from Professor Suna, and all cotrimoxazoles can cause red cell hemolysis, but it would be unusual to use it in a newborn infant. The other question is from Okello. Is metalloporphins recommended in the management?
I saw this, and I think I would, I saw this in terms of when I was kind of reading around this, basically, in terms of management, but I honestly didn't go into details in terms of whether it can be used or not. So it's something maybe I'd refer to maybe Professor Suna or someone else to kind of comment on it, basically. I haven't used it and I haven't seen it being used, basically.
Okay, as we wait a response, maybe from Professor Suna, I'll just go to the next question from Bahati. So they had a baby who underwent phototherapy, but the bilirubins kept rising. IVIG was given, still no difference. Then O negative blood was donated and didn't match. They got another O negative donor. In such a case, what could have happened to the first O negative cross match that didn't match? Have you ever encountered such a case, and the procedure took place in?
I think there are other antibodies that could be present that we usually may not be screening for, basically. So I'm not sure whether that was the case, and I'm not sure whether I'm answering your question correctly. So other than your ABO and rhesus factors, there are other antibodies that are present in the blood, basically. So I'm not sure whether that may have been the issue in terms of matching or not matching, basically. Yeah, that could be the issue, basically, in that particular situation. And it also depends on whether one individual had had a transfusion before or not, and then was it a transfusion that probably didn't match, and so they were sensitized before, and so that then predisposes them to like a cross match that goes wrong, basically.
Thank you for that. The next question, I think we are coming to the end, is on the blood that you use for exchange transfusion. So they're asking how fresh is fresh blood?
As close as possible to less than 5 days. So less than 5 days would be the appropriate, so closer to less than 5 days, basically. So if it's donated 2 days ago or 1 day ago, then that's the best, as opposed to the one that was donated 5 days ago, basically. So that's the one you would want, basically. So as fresh as possible. Was that the question? I think that was the question.
Yes, it was. Thank you for the response. Just trying to see if there's anything else. I think you've answered most of the questions, and then because of time, I think we will wrap up. So I'll just kindly ask you to give any parting shots, something that you'd like all the participants to remember when they are evaluating a patient who they suspect to have neonatal jaundice, and also for the management.
I think the parting shot is whenever you're attending a delivery or dealing with a newborn, it's always good or important to know what the antenatal history was like. Find out as much as possible the information. Mom's blood group is very important to know. Any other infections they may have had, especially touch infections, because for you to manage a baby well or properly or anticipate anything, it's always good to be forearmed with some information, basically. And then if you're concerned, please screen. And I know a lot of places are not able to do transcutaneous bili. So please just do a bilirubin, because as much as you think that it's not a significant level, you have no idea. And in some situations, sometimes you might think it's not exchange level bilirubin, but the baby is actually starting to show some significant issues, basically. And then always use the charts. I think they're very helpful. Pick one chart and then just use it for that specific baby so that you don't miss anything. I think that's it.
Thank you. Okay, thank you for that. I'm seeing Prof was asking about the question. Maybe I'll just repeat it if we can get a response. The question from Okello is if metallopofurins are recommended in the management of neonatal jaundice. Prof, I don't know if you're still there. I think I can see him. So I've seen the response from Prof. He says no, it is not used. I just want to thank you all. I think we've gotten to the end of our presentation. I just want to thank you, Dr. Okara, for taking the time to make this very elaborate presentation and very interesting presentation. And thank you to everyone for attending. I think I'll hand over to Nelson to just give any comments about the CPD points or any other future presentations. Thank you.
All right, thank you, Dr. Kalemi, for having a wonderful session with your team. Also, thank you, Dr. Okara, for your very insightful presentation. For the CPD points, I have answered most of the questions on the Q&A section. We always encourage you to send us an email to knhcpd@gmail.com stating the events you haven't received points on. We normally maintain all attendance lists, and we will obviously backdate and check the status of your attendance in this events that we hold, and if there was a mistake, we will issue you your CPD points. So kindly email knhcpd@gmail.com. We have a high correspondence of the emails that we normally receive, so kindly be patient. Our team will be able to pick up your email and be able to sort you as well. For upcoming sessions, tomorrow we are having one public forum on cervical cancer. You are all encouraged to join. We have been sending out the link, the registration link for you guys to register and be able to attend the session tomorrow. So kindly join us and also share that link with your family and friends. And we look forward to seeing you tomorrow. Thank you for joining us for this session once again today, and do have a wonderful evening. Goodbye. This has been Nelson from KNH Research.